Greetings and welcome to this video on Oxazolidinones. In this video, we'll discuss about Linezolid and Tedizolid in detail. We'll discuss about the mechanism, the toxicity, and the clinical use of this drug uh, on par with the standard ICU protocols and for the physician's perspective. If you're new to this channel, subscribe. This is Medicine Beyond Harrison's. Let's get started. So, the big picture Oxazolidinones antibiotics includes the Linezolid and Tedizolid, which is primarily a gram-positive agents. Rural and IV availability is almost 100% with excellent effect penetration and key role in drug resistant infections are there. It has a high toxin suppression property also can be used for MRSA and MSSA that produces toxins also. So these are the major overall overview about these drugs. These are it's excellent gram positive coverage agents even for enterococcus it covers. So mechanism is binds to the 50S ribosomal subunit and inhibits the 70S initiation complex. So it is a bacteriostatic versus most organisms and bactericidal against only some streptococcus species. So it suppresses toxin production completely. So crucial in necrotizing infections and toxic shock syndrome patients. So wide class advantages there because of the high bioavailability, almost 100%. Oral is almost equal to IV bioavailability with excellent CNS and lung penetration for linezolid. It covers the resistant organisms such as MRSA, Vancomycin resistant enterococcus, penicillin resistant pneumococcus, and no beta-lactam cross-reactivity. That is one more major advantage. So contraindications are very less. Only neutropenia for tedizolid and for linezolid, concomitant serotonergic medications can be avoided in view to avoid serotonergic syndrome, serotonin syndrome. So it is a related contraindication. We will discuss more in this the upcoming slides. So because of reduced efficacy in neutropenia of prednisone, it is likely dependent on the accumulation within the phagocytes. So cannot be used in case of neutropenia. So drug interactions, linezolid, decreased levels of linezolid can be there in uses of enzyme induced such as rifampicin, phenobarbital, and penicillin, and increased levels in case of enzyme inhibitors, cytochrome enzyme inhibitors such as Oswald drugs, amiodarone, and ticagrelor. So now all these drugs try to avoid linezolid because it can lead to increased levels of linezolid and lead to toxicity. Tedizolid is minimum clinically relevant interactions can be used safely in most cases. Linezolid can cause reversible non-selective MAO inhibitor. So it risk with SSRI, SNR, ATCase, monomonoxidase inhibitors, triptans, and trembolone. All these drugs can lead to serotonin syndrome. So ideally, stop any serotonergic drug and give a warning period for time and then start a linezolid drug. Don't start linezolid simultaneously. If you start, then monitor it very closely to prevent any serotonin syndrome. So, but the actual incidence is comparatively very low, but the risk is overstated. Still, consider this in your clinical practice to avoid legal errors. So, adverse effect profile can cause nausea, vomiting, and diarrhea. Linezolid is very notorious to cause this gastritis, abdominal symptoms with protracted vomiting and nausea. So, try to avoid in case of gastritis or give a coverage with pantoprazole or inhibitors. It can lead post-irreversible encephalopathy syndrome, seizures, and also hypoglycemia. So mitochondrial with prolonged therapy for more than 15 days it can lead to mitochondrial toxicity due to inhibition of mitochondrial protein synthesis. So try to avoid it with prolonged therapy, no more than 14 days. Can lead to myelosuppression, which is reversible, especially thrombocytopenia is more common, neutropenia and anemia. So important nuances that that can in nosocomial pneumonia, there is no significant increase in thrombocytopenia versus comparators. So it is nowadays considered not the most important cause of thrombocytopenia, but still needs to be used with caution. Can lead to optic neuropathy, which is usually reversible. Total neuropathy may become irreversible if drug is not stopped, and also lead to lactic acidosis due to mitochondrial dysfunction. These adverse effects needs to be kept in mind. So don't give in a patient with optic neuropathy or in demyelinating disorders or in any nervous issues like peripheral neuropathy, try to avoid linezolid and or keep it as a last option. So there's important protective effects. So these are also advantages. It is protective against cross-stream deficit infection. Does not increase the vancomycin resistant enterococcus prevalence, unlike vancomycin. So tedizolid is better tolerated than linezolid with very few side effects, with lower mitochondrial risk, very few GI side effects can be given. So when to choose linezolid? So it's a very safe for short dosage therapy. Toxicity increases only after 10 to 14 days. It requires prolonged monitoring with prolonged therapy. So it can, when compared to vancomycin, daptomycin, and ceftriaxone, it can be used for lung CNS penetration with excellent penetration. So it can be used for that. In case of toxic suppression, can use. In case of renal function is not good. When there is elevated creatinine or CKD patients, you can use linezolid without any dose monitoring, dose alteration. So it is a first line agent for MRSA pneumonia. Evidence supports superiority even over vancomycin. So it's also active against MSSA and Streptococcus pneumonia, but still it's not the first line because it's predominantly a bacteriostatic drug than not a cidal drug. So MRSA bacteremia, vancomycin is good because vancomycin is a cell wall inhibitor and can be bactericidal, whereas linezolid is not a cell wall inhibitor. So vancomycin resistant enterococcus bacteremia, and linezolid is the FDA first line drug. So vancomycin is not the first line drug for VRE. Since an FDA warning likely statistical aggregate, but subsequent studies show efficacy against vancomycin resistant bacteremia also. Linezolid is FDA approved for VRE bacteremia and not for MRSA bacteremia, still vancomycin is preferred. In case of UTI, it is not primarily excreted in urine, but still if you suspect a vancomycin resistant enterococcus in the urine, urinary concentration are reached in adequate concentration more than serum levels, so it can be used. And for skin and soft tissue infection, more active than vancomycin because of toxin suppression and excellent oral symptom option. It can be considered as a excellent oral symptom option. For necrotizing and toxic shock syndrome, increasingly preferred because of toxin suppression and broad coverage, avoids vancomycin toxicity also. For CNS infection, it's a very good CNS penetrating drug with around 70 to 80% effect. Can be used as an alternative regimen compared to ampicillin and vancomycin regimens in case of pneumococcus and listeria. It can combine with ceftriaxone plus linezolid combination. This is also one of the known regimen used for these organisms. So complete spectrum is MRSA and vancomycin resistant Staphylococcus aureus, vancomycin resistant Enterococcus, coagulation exercise Staphylococcus, Streptococcus species, penicillin resistant pneumococcus, listeria, and nocardia. These are the entire spectrum of linezolid and tedizolid. So tedizolid the spectrum is similar to linezolid, covers some linezolid resistant strain also. It's preferred when there is GA intolerance to linezolid, when there is requirement of prolonged therapy for more than 15 days, and there is concern for serotonin syndrome. So dosing is 600 milligram IV or oral, give twice hourly for linezolid. There is no renal adjustment. The same dose provides meningeal coverage also. In case of morbid obesity also, there is usually no dose adjustment. It can be increased Q8 hourly, but may increase toxicity also. So in case of augmented renal clearance, consider Q8 hourly or in continuous infusion of linezolid. In case of patients with ECMO, variable levels are there. Supplement may be a better option for MRSA stains. Tretinoin is standard regimen is 200 milligram once daily dosing. No renal adjustment, no hepatic admission, no dialysis adjustment. Just once daily dosing of 200 milligram every other day. So pharmacologically, it's 337 gram per mole molecular weight with availability of almost 100 per 1 to 2 hours. And the full delays peak but not explosions. 100% bioavailability. It is 30% protein bound with a comparatively low volume of distribution and excellent lung and CSF penetration. And then it is degraded by non-enzymatic oxidation and no cytochrome P is involved. In case of renal dysfunction, only 30 to 35% is extruded unchanged in kidney through kidneys. So it's not a major issue. Half-life is 3 to 7 hours for linezolid. In case of tedizolid, it's more lipophilic with around 90% oral bioavailability and more volume of distribution compared to linezolid. It's also a very good tissue penetration. CSF penetration is unclear, so do not use it for CNS infection and it's not approved. Elimination is by biliary route and less than 3% is excreted renally. Half-life of around 11 hours. So yeah, one final slide comparing linezolid and tedizolid. Tedizolid is given once daily dosing. This is given twice daily dosing. GI side effects are more in linezolid, and mitochondrial toxicity is higher. Also, the serotonin syndrome is present with linezolid. All these are lower in tedizolid. It's a newer drug. With the long-term use preferred, tedizolid is preferred, and not the linezolid. The final key takeaways like linezolid are Workhorse anti-MRSA and vancomycin resistant enterococcus strains. Tedizolid is safer for long-term usage. Yeah, it has outstanding lung and CNS penetration. So it is the drug of choice for vancomycin resistant enterococcus bacteremia and MRSA lung infections. Always monitor toxicity after 10 to 14 days of therapy. There is a risk of serotonin syndrome, but although the risk is overstated, it is present. So I hope you learned Linezolid and Tedizolid. Also really do any notes in this video. If you are new to this channel, do like and subscribe. This is Medicine Beyond Horizons. Let's meet in another video in this antibiotic series. Thank you for watching.